السلام عليكم ورحمة الله وبركاته. اليوم والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم ننهي موضوع الإميونو سبريشن والكدني ترانسبلانت. هنتكلم عن الأذر uncommon used medication in kidney transplant. وهنتكلم عن الكامباس اللي هو الميتوزوماب Human Monoclonal Antibody Immunized IgG. It will be target CD52 25 كان البازيليكسيماب اللي بنستخدمه في الاندكشن. هنا الالميتوزوماب also بيستخدم برضه في الاندكشن وفي الريجكشن، وهو بيشتغل على الريسبتور اللي هي CD52 مش 25 بتاعت البازيليكسيماب. ده موجود على السيرفيس بتاعت T and B cell lymphocytes and his work just like T cell lymphocyte depletion and given only just commonly one or two doses IV or IM, usually given just single dose 30 milligram IV once, approved for treatment lymphoma and leukemia before, and currently used as induction therapy for treatment also as induction therapy for kidney transplant, also for treatment of rejection. There is a site of action of almituzumab anti-CD25 here 52. يعني الريسبتور دي بيعمل لها ديبليشن، طبعا بيعمل انكتيفيشن للتي سيل اكتيفيشن اند بروليفريشن. الميتوزوماب here also just another diagram just shows this بيلعب على السي دي 52، بيلعب على التي سيل انهبيشن او ديبليشن او ديستركشن. الميتوزوماب the side effect for like this campus just severe leukopenia, infusion associated reaction, severe allergic reaction, sometimes headaches, rash, fever, nausea. It should be pre-medicated also like thymoglobulin or ATG, GI upset, headache, sleep disturbance also. Next medication will speak about Belatacept. Belatacept is also another medication given monthly by injection intravenous infusion to 250 milligram per vial. بيلعب على التي سيل كو ستيميوليشن بلوكين سيجنال 2 blocking agent. Belatacept has been identified as a possible substitute for calcineurin inhibitors if you have your patient can tolerate C9 either from TME or another patient who didn't like to do frequent blood monitoring and adherence and some fibrosis or issue with complication with CNI, whatever the side effect of CNI as we mentioned before, we can use this Belatacept is given monthly already. Is not strictly monoclonal antibodies, a fusion protein of CT lymphocyte A4, extracellular domain, IgG, FC portion, FC domain of human IgG1, work on P7 and CD80 and CD86 of antigen presenting cell that join or interact with CD28 on the T cell inhibitor, inhibits T cell co-stimulation. من الدندريتك cell antigen presenting cell we have this CD80 86 which join in CD28 on the T cells 80 86 28. FDA approval in 2011 for maintenance and rejection. Comparable with CNI Belatacept decrease donor-specific antibody and the cardiovascular side effect used in place of calcineurin inhibitor if calcineurin can tolerated for any other severe any side effect. Just require IV administration. And where is the action of this Belatacept here? Antigen presenting cell CD8086, T cell CD28. It will block this one. Blocked by this medication Belatacept will block signal 2 and no more activation of the cell proliferation or T cell activation. Belatacept, as we mentioned, antigen-presenting cell receptors. The antigen-presenting cell like dendritic cell, it will present this antigen and the processing and excrete this antigenic part of this antigen on the receptors CD8086. It will interact with the receptors on the T cells CD28. This will activate signal 2. Signal 1, we remember major histocompatibility type 2 and another peptides. And the receptors here on antigen-presenting cell will present the antigen to T cell receptor or CD3 and activate signal 1. And signal 2 is important for activation of signal 1. Without signal 2, the cell cycle activation will be arrested or stopped or blocked. Co-stimulation blockade signal 2 T cell require co-stimulation for full activation. It will be blocked by Belatacept now between the antigen-presenting cells CD886 and T cell receptors CD28. That will signal will be inhibited by no more T cell activation by Belatacept. I hope it's clear now. Again, Belatacept here is more potent, second generation. Abatacept, a high affinity, just again for the same receptors and inhibiting full T cell activation. Just only this slide for this part. Belatacept already dose 5. Sorry, this E, not A. Belatacept the dose 5 to 10 milligram per kg in 250 normal saline over 30-minute IV infusion in peripheral vein. De novo induction. 10 milligram per kg at day 1, day 5, and week 2 and week 4. Then high or low dose protocol. This is a little bit different protocol. If you will use this one, you will know how to use this Belatacept because it's rarely used already in Canada. Maybe used in Abu Dhabi a lot for most of the patient. And this again another diagram just show how this Belatacept disrupt this interaction for co-stimulatory signal 2 block T cell activation between CD886 and CD28. No interaction here, no signal 2, no T cell activation, no cell divisions, no cytokines release, like this. We have this high dose protocol and low dose protocol, either 10 milligram per kg every 2 weeks, months 2, months 3, 10 milligram per kg months 4, 5, and 6, 5 milligram per kg per month after that. Low dose protocol 10 milligram per kg months 2 and 3, 5 milligram per kg per month after that. Months. Belatacept side effect mild increase in PTLD. This is a side effect for this, especially ABV mismatch. We can't use Belatacept. If you have donor positive and recipient negative ABV PCR screening before transplant, care you will put your patient on high risk for PTLD as a side effect or ABV virus infection post transplant. Mild increase in also virus infusion reaction and infection rate as CNI, also same, I think same infection rate as immunosuppression for most of the medication. Post-transplant conversion from CNI to Belatacept. Belatacept 5 milligram per kg every 2 weeks, 5 doses and 5 milligram per kg monthly. CNI tapering after 2 weeks, 40 to 60% of CNI level after 3 weeks. After at third week, 30%. After 4 weeks, you can stop CNI. This to transfer from CNI to Belatacept. But I don't have a lot of experience with Belatacept already, but just I mentioned this as a immunosuppression we can use post-transplant. It was not commonly used in Canada. Rituximab is a monoclonal chimeric antibody against CD20 found on the surface of B cell, approved for treatment of B cell lymphoma, used as a part of desensitization protocol or treatment of antibody-mediated rejection or recurrence focal segmental glomerulosclerosis, not an approved indication, and rarely I saw in antibody-mediated rejection but commonly I saw in recurrence focal segmental glomerulosclerosis. Several humanized or human anti-CD20 are being developed for lymphoma and autoimmune disease, used off-label in transplant medication depletion of CD20 expressing B cell. Also, the second generation CD20 high affinity bind and improved antibody dependency T cell mediated toxicity compared to rituximab, and the action of these monoclonal antibodies during the receptors on the beta cells and the receptor antibody complex. This will end by antibody dependent cell mediated cytotoxicity and complement dependent cytotoxicity and apoptosis, and then will lead to B cell lymphocyte cell death and depletion, and this will decrease antibody production, especially antibody mediated rejection or circulating antibody with recurrent focal segmental glomerulosclerosis. Monoclonal antibody against CD20 on lymphocyte rapid depletion for at least 6 months, initially for treatment non-Hodgkin lymphoma, We are used in desensitization, especially preformed antibodies with highly sensitized patient. Positive cross-match or AB-uncompatible is common with AB-uncompatible, and we'll have a separate talk for AB-uncompatible transplant, treatment of acute humoral rejection, treatment of recurrent post-transplant focal segmental glomerulosclerosis, and we used already in around 4 patients over the last years, and treatment of PTLD post-transplant lymphoproliferative disease with positive CD20 is commonly used also. Dose 375 milligram per meter square over 6 to 8 hours, 1 to 4 doses weekly. Side effect and طبعا anaphylaxis for like other medication allergic reaction. You should pre-medicated by diphenhydramine, acetaminophen, and steroid if possible. And fetal hepatitis, screen for hepatitis B infection. For reactivation, you should your patient immunized and not core positive. And progressive multiple leukoencephalopathy also is a rare side effect. PML, progressive multiple leukoencephalopathy. I will go to IVIG, intravenous immunoglobulin. We are using intravenous immunoglobulin a lot, especially with antibody-mediated rejection, with BK virus, parvovirus, and or most of the infection, CMV also infection. What is the mechanism of action of IVIG? This is a common question. Why are you using IVIG? Remember IG immunoglobulin already composition, FEC, and antibody modulation. It will alter FECY receptor expression and function, provide anti-idotypic antibodies, neutralize donor-specific antibodies, making neutralization for this DSA or donor-specific antibodies. Complement pathway blockade, inhibit C1q binding, prevent complement activation and tissue injury. Also play in cytokines, immune network regulation. Balance pro and inflammatory cytokines, limit rejection and inflammatory هنا عندنا على cytokines anti-inflammatory, complement blockade, and antibody modulation and neutralizing any donor specific antibodies. على dendritic cell effect, inhibit maturation, antigen presentation or processing on the dendritic cell surface or antigen presenting cell surface. This will inhibit T cell activation. T cell modulation, reduce activation and proliferation from the previous mechanism, enhance regulatory T cell expansion. B cell suppression, inhibit activation, also proliferation from the previous mechanism, reduce plasma cell survival and antibody production. Effect on cell inhibition also, it will inhibit cytotoxic T cells and dampness cytotoxic T cell and natural killer T cell activity, protect against graft injury. Intravenous immunoglobulin preparation are made up of IgG type antibodies which recruit virus into lymphoid organs where they are presented to P and T cells, leading to an activation of immune response, and especially in BK and CMV virus or parvovirus. In this diagram show all what we said before, mechanism of action of IVIG from neutralizing antibodies, especially with focal segmental and soluble antibodies, and this antibody-mediated rejection post-transplant and inflammatory complement blockade, antibody-dependent cellular cytotoxicity, and regulate B cell antibodies production already, inhibition, activation of T cell proliferation. All this diagram just show the mechanism of this IVIG. So just to remind this main 3 things you should remind: neutralizing of circulating antibody, especially preformed antibodies DSA with AB incompatible, inhibit lymphocyte proliferation, antibody-mediated rejection, anti-inflammatory cytokines, especially in viral infection post-transplant. That's the main, these 3 main 3 mechanisms. And from all this diagram also, it will make it easy for you to remember all mechanism of action of IVIG. Is intravenous immunoglobulins block normal preparation from antibodies from thousands of blood donors. جاي من الهيومن من they collect 1000 antibodies from the human blood donors. A variety of immunomodulatory effect on multiple elements of the immune system has been used for desensitization pre-transplant, prophylaxis in transplant at high risk, antibody-mediated rejection, treatment of antibody-mediated rejection, but no really an approved indication. But most of the transplant schools here or hospital used as in their protocol. Initially used for treatment of humoral immune deficiency disorder, but currently we are using an antibody-mediated rejection after plasmapheresis, and we are using a recurrent focal segmental glomerulosclerosis, and we are using in BK virus. A lot of patients needed IVIG, and we are using in parvovirus treatment, and we are using in CMV. IVIG usually does in antibody-mediated rejection and the severe BK virus 2 gram per kg, maximum 140 over 8 to 12 hours, given after plasmapheresis in patient with focal segmental or antibody-mediated rejection. IVIG used to reduce the high level of preformed anti antibodies in sensitized patients, especially when it's APM compatible, and we'll come to this talk in future to facilitate living donor transplant with patient APM compatible. We'll come to this to treat acute humoral rejection, to treat post-transplant infection, especially with BK and parvovirus, and recurrent focal segmental glomerulosclerosis. The side effect, as we mentioned, allergic reaction less than 5%, sometimes aseptic meningitis, give non-steroidal before, but is contraindication post-transplant, thrombosis, myocardial infarction, AKI, sorbitol, sucrose, and osmotic diuresis will end by ATN, and also some little bit pseudohyponatremia. Again, just to remind you what is the mechanism of this IVIG, we just summarizing this slide again, or this diagram, to be easy for you to review. And we have lastly leflunomide. Leflunomide usually as we're using with severe BK and BK nephropathy, especially with BK nephropathy and resistance to treatment. And the mechanism of leflunomide. Leflunomide, it will transfer to, once you are taking leflunomide, it will be converted to active metabolites A77 107026, inhibit the mitochondrial enzymes dihydroortate dehydrogenase DHODH, and this will disrupt the de novo of the pyrimidine synthase necessary for lymphocyte proliferation. I hope this pathway just for inhibit DNA and this RNA and DNA replication or translation that will end by activation of T cell lymphocyte proliferation, and this is the mechanism of action pyrimidine synthase inhibitor. Leflunomide block A77 1072 6 metabolites will end by DNA synthesis blockage, decrease T and B cell proliferation, decrease cytokines interleukin 2 inhibitor, and increase tumor growth factor beta 1 regulatory and antiviral against BK virus nephropathy, protect graft function while controlling virus infection. Again, just to remind, this mechanism of action of leflunomide pyrimidine synthesis inhibitor, DNA blockage via this inhibition of this dihydroortate dehydrogenase, approved for treatment of rheumatoid arthritis, currently used for BK virus nephropathy, especially with severe cases, possible replacement to mycophenolate or azathioprine antiproliferative in patients with BK virus, not an approved indication. And this pharmacological effect of leflunomide, just I mentioned here, just anti-cancer and also used in rheumatoid as anti-arthritis, multiple sclerosis, neuroprotective also, and the anti-cancer and the antiviral here we are using for BK virus post-transplant. Risk factor for BK virus post-transplant, tacrolimus, acute rejection, male gender and age, ureteric stent, cadaveric transplant, especially after cardiac death, and previous transplant, delayed graft function. All this risk factor for BK virus, especially leflunomide post-transplant, mainly used for BK virus nephropathy. Final point to close the immunosuppressive medication post-transplant chapter. We have a variety of we have a variety of immunosuppression medication are used in transplantation. Understanding mechanism of action is crucial to proper use. Medication are used in combination to reduce the rejection rate, improve long-term graft survival, and mitigate side effect. And thank you so much. والسلام عليكم ورحمة الله وبركاته. ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ولا تنسونا من صالح الدعاء، ونلقاكم بفيديو قادم إن شاء الله بموضوع جديد. إن شاء الله نتكلم عن الغرض من الموضوع ده كله، ان انت بحاول اوصل لكم الحاجات اللي هي فعلا بتستخدم في الكلينيكال وبطريقه مبسطه بعيد عن تعقيد الكتب والمحاضرات الرسميه والكلام ده كله. انا بحاول انقل لك بروتوكولات، بحاول انقل لك الدنيا ماشيه ازاي، بحيث انت لما تقابل مريض تشوف الدنيا تتعامل معاه ازاي. او عايز تعمل بروتوكول تجمع اللي انا بقوله ده وتعمله بروتوكول تظبطه عندك في المكان على حسب امكانيات المكان اللي عندك. والله المستعان دايما. يا رب يجعله علم ينتفع به دائما. ولا تنسونا من صالح الدعاء، ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. والسلام عليكم ورحمة الله وبركاته.